Okay, so I see that more people have joined, and I think we can start for today. So, do you have any questions regarding the presentations so far or the online classes? Uh, we talked with some of you and also with other people from the department that it would be best to continue our exercises online, at least for right now. And maybe in a couple of weeks, we'll see, depending on the situation at the hospital, how we are going to proceed. As you know, the whole hospital, excluding the obstetrics and pediatrics, is a COVID hospital right now, and at the cardiology, we're also um, COVID intensive care unit. So it's really not an option to do classes alive and for you to see patients. And I'm talking about especially your clinical activities. But I hope it's something temporary and we'll be back to normal. So to continue with today's exercise, um, I'll not go into full screen because there is a problem when I'm changing the slides. You cannot see them, so that's why we are going to talk about heart failure today and also deep venous thrombosis and pulmonary embolism. So to start with the definition of heart failure, it's a complex clinical syndrome that can result from any structural, and structural means any problems with a heart valve, like aortic stenosis can be a structural heart disease. Also, ventricular septal defect can be a structural heart disease, or an atrial septal defect or an ASD can be a structural disease, and they can cause heart failure, or a functional cardiac disorder that impairs the ability of the ventricle to either fill with or to eject blood. So, according to this definition, we can have two types of heart failure. One type is called HFrEF. It means heart failure with reduced ejection fraction, when there is a problem with ejection of the blood. And another name for HFrEF is systolic heart failure, because uh, you know that during systole the heart contracts. So when there is a problem with the contraction, we call this systolic heart failure also. And usually in this type of heart failure, the ejection fraction is below 40%. This is actually the heart failure that we have many drug alternatives for. So a lot of options to prolong the survival of these patients and to reduce their symptoms. This is not the case with HFpEF, or heart failure with preserved ejection fraction. This is also called diastolic heart failure because there is a problem with filling of the blood in this type of heart failure. And in diastolic heart failure, the ejection fraction is actually preserved. That's why it's called HFpEF, and it is about usually 50%. In this type of heart failure, the patients have similar symptoms, like most commonly they have fatigue, they have dyspnea, and echocardiographically their hearts show preserved ejection fraction, and we are going to see um, what causes can lead to HFpEF and HFrEF. Again, we divide um, heart failure according to uh, problems with either filling and ejection of the blood to systolic or diastolic heart failure. If the left side of the heart, especially the left ventricle, is with a reduced ejection fraction, we call this left-sided heart failure. If the problem is with the right ventricle, we call this right-sided heart failure. Also, according to the time during which the heart failure develops, we divide the heart failure into acute and chronic. Acute is usually due to something like acute coronary syndrome or myocardial infarction. It can also be due to some rupture of um, the chordae of the mitral valve, let's say, due to infective endocarditis, or due to, again, myocardial infarction. It can also be due to an acute aortic dissection, causing acute severe aortic regurgitation. So these are all causes of acute heart failure. And the causes of chronic heart failure, we're going to be focusing more on them today. So this slide shows you in the middle a normal looking heart with the left ventricle, as you can see, having this is the left ventricular free wall, and this is the septum, and this is the right ventricular free wall. And if you compare the left ventricular free wall to the right ventricular free wall, you can see that this here is a lot thicker, the left ventricle, because it needs to pump the blood against more a lot higher pressures in the aorta, and the right ventricle needs to pump the blood to the pulmonary artery and to the lungs, which usually have pressures 4 or 5 times lower than the pressures in the left system. This here is an example of a heart with systolic heart failure, and you can see the left ventricle is balloon-like. It looks like even like a big aneurysm. You see the usual bullet shape here is not present. It's more like a ball-like heart. The left ventricular ejection fraction is low. The left ventricular muscles are weak, and they cannot pump the blood to the aorta. So there is a buildup of fluid in the lungs, and this causes the patient symptoms of usually fatigue and dyspnea. This here is a heart with a diastolic heart failure, and you can see that the left ventricular wall is even thicker than the left ventricle here, which is the normal left ventricle. And this can be caused by arterial hypertension, by long-standing arterial hypertension, which is not treated. So if for 5 or 6 or even more years, the patient didn't get enough therapy, and the patient's blood pressure was, let's say, 140/90, even though it's not a very significant blood pressure and not very significant arterial hypertension, it can still lead to left ventricular hypertrophy because the pressures in the aorta are greater than the usual. So the left ventricular wall needs to contract against a higher pressure, and this with time leads to left ventricular hypertrophy, and this leads to higher pressures in the left ventricle and higher pressures also in the left atrium, which causes problems with filling of the left ventricle because the pressures here are higher. It cannot fill normally with blood, and this again causes symptoms of dyspnea and fatigue. I think we talked about the mortality from heart failure in 5 years, and this is really a huge percent, at least in my opinion. So 50% of people with heart failure are going to die in 5 years, and this is even more than some forms of cancer. Uh, and heart failure, as you know, is not a very rare disease. It's actually very common. So if these patients are not treated in the best way possible, half of them are going to die, unfortunately, in 5 years. That's why you should be really familiar with the diagnosis and also the therapy of such patients. This is the classification system of heart failure. The NIHA classification system is based on the functional class of heart failure. So when does our patient get symptoms? If it's class 1, usually they have no limitation of physical activity, and ordinary physical activities like walking to the market doesn't cause them any problems. But they feel um, some symptoms like fatigue, palpitations, dyspnea, or sometimes angina if they also have ischemic heart disease, with physical activities that are above the normal. Class 2, they feel comfortable at rest, but they have a slight limitation of physical activity. And class 3 is when they have marked limitation of physical activity. And class 4, as you know, is when they have discomfort at rest. So even though they're not involved in any physical activity, they still feel that they are getting tired and they have dyspnea. Another classification is the AHA classification, which divides the different patient groups into stages. So stage A, B, C, and D. Stage A are patients who have a risk for developing heart failure, but who have not yet developed structural heart changes. And these are patients with diabetes, let's say, with coronary artery disease. Stage B are patients with structural heart disease that has developed, so reduced ejection fraction, left ventricular hypertrophy, left atrial enlargement can also be involved in this stage, can be included in this stage. Stage C is when these patients have clinical heart failure, so they're right now symptomatic. So this is the big difference between stage B and stage C. Stage B are still do not have symptoms of heart failure. Stage C have symptoms of heart failure, and stage D are these patients who are refractory to heart failure therapy, and they need more special interventions like biventricular pacemakers or CRTs. These are a special type of pacemakers that can pace both the right ventricle and the left ventricle. They're called cardiac resynchronization devices, so CRTs. Cardiac resynchronization therapy, so CRT. The T stands for therapy. And we have two types of CRTs, type D and type P. They have the D type has the function to defibrillate. So they're similar to the ICD or the implantable cardiac defibrillator devices. And the CRTP type of CRT device is the normal CRT device that has only pacemaker function. That's why it's called CRTP. Left ventricular assist devices, or LVADs, are used in stage D, and also they are candidates for cardiac transplantation. The major causes of heart failure is of course, coronary artery disease. It can be chronic uh, coronary artery syndrome, or it can be acute uh, coronary syndrome. And as you know, acute coronary syndrome includes unstable angina. It also includes myocardial infarction. And with time, if not treated in the best way possible, they can lead to heart failure. Hypertension, we said that if, again, not treated, if it's long-standing, it can lead usually to diastolic heart failure or heart failure with preserved ejection fraction. So HFpEF, valvular disease like aortic stenosis, aortic regurgitation, mitral regurgitation, they can all cause symptoms of heart failure. Diabetes can help the progression of coronary artery disease and can also lead to heart failure. Less common causes here include myocarditis, tachyarrhythmias like atrial fibrillation are actually not a very rare cause. They are relatively more common. Congenital heart defects. So this is a special topic in cardiology and in pediatrics. And because nowadays the care for patients, especially for children with congenital heart defects, has advanced um, in the last 30 to 40 years, and their survival is greatly um, increased. A lot of special cardiology hospitals have departments for adults with congenital heart defects. So we are going to see more and more adult patients who were born with a congenital heart defect, and they were treated either surgically or medically, and they survived to adult years, and you are going to be taking care of such patients also. So it's a complete new or relatively new subject of cardiology. Cardiomyopathies can also lead to heart failure, and you know there are several types of cardiomyopathies. It can be hypertrophic cardiomyopathy, dilated cardiomyopathy. They're the more common types, and also restrictive cardiomyopathy, which is more rare. Pulmonary causes, rheumatologic causes, infiltrative causes are less common causes of heart failure, and also thyroid disorders. It's always a good idea to check for thyroid function. Such patients with symptoms of heart failure, especially if they have some sort of an arrhythmia, like atrial fibrillation. How patients uh, present, they usually have dyspnea and fatigue. These are the more common presenting symptoms, and again they can have edema in uh, the lower extremities usually, and if especially if it's pitting edema, and they have a weight gain, which is not explained by diet. This is also a sign of heart failure uh, that has developed and is starting to progress. Uh, Another thing that is very important in examining these patients with heart failure is, of course, the physical exam. Most commonly, when you auscultate these patients, you can hear urales. Um, they're usually found in the uh, pulmonary base. So, uh, if of course they don't have pulmonary edema, which develops acutely and they can have rails all over their lungs. In this case, they have distension of the jugular veins. Sometimes you can hear yellow written S3 or S4 is also possible. Ascites, if the heart failure is more to the right side, so if it's a right-sided heart failure. The diagnosis includes actually a lot of exams besides the history and physical. EKG can show us some myocardial infarction, which can be acute or which can be old. If we see, let's say, QS complexes instead of the normal QRS complex that is seen. We can also detect left ventricular hypertrophy. The chest X-ray is a very simple exam, but it's very helpful in the diagnosis of heart failure, and it can show us pulmonary venous congestion or interstitial edema. It can also show us cardiomegaly. Labs, troponin, arterial blood gases, thyroid tests, they're all important. The complete blood count cannot show us really anything related to heart failure, but troponins are important. Uh, Also, echocardiography to assess the left ventricular ejection fraction, whether if it's above 50% or whether if it's reduced. Also, we didn't mention that there is a ejection fraction between 40 and 50%. That is moderate. Uh, it has different names. Sometimes it's called moderately reduced ejection fraction or mid-range ejection fraction, and it's shortened as HFmF, so heart failure with mid-range ejection fraction. And it is usually treated in the same way as reduced ejection fraction. Another exam is the BNP or brain natriuretic peptide. The more specific type is NT-proBNP, and it has a very high sensitivity and specificity in diagnosing heart failure. And if it's below 100, it's very unlikely that your patient has heart failure. If it's above 400, it's very likely that your patient has heart failure. So this test is sometimes used in the emergency departments if you don't know and if you are not sure about the cause of the symptoms of your patient, like dyspnea and shortness of breath. They can also have um, coughing. So you're thinking maybe this patient has pneumonia or maybe this patient has heart failure. And this, along with the history, with the physical, with other blood tests like inflammatory markers, can help you determine whether the patient's symptoms are due to mostly heart failure or to pneumonia or some other pulmonary cause. The management of heart failure, of course, we have a lot of drugs, but before the drugs, we cannot forget about the lifestyle modifications that with most of them you're familiar from the exercise about arterial hypertension and ischemic heart disease. So we have the vaccines like pneumococcal vaccine, the influenza vaccine, and nowadays the COVID, of course, vaccine. The low sodium intake is especially important in such patients because you know that salt, which is sodium chloride, leads to a fluid buildup in these patients. And this is actually the main problem in heart failure. especially if they have a low ejection fraction. This could be really important for such patients not to take so much salt, so they don't develop symptoms, or for their existing symptoms not to become more severe. Alcohol and smoking cessation are very important. Some medications should be avoided in these patients, like NSAIDs, because they can reduce the GFR and they can also worsen the response to diuretics and ACE. Um, Acetylsalicylic acid, we said that it has a value in the treatment only in coronary artery disease or atherosclerosis that is already diagnosed. So it's for secondary prevention, not for primary prevention. Some antidiabetic drugs, thiazolidines, should be avoided. Metformin is actually used in patients with heart failure because it's the first-line treatment for type 2 diabetes. Some phosphodiesterases like PDE3 and PDE4 should be avoided. And now comes the question, what should not be avoided in such patients? We shouldn't avoid to include in patients with heart failure in their therapy the following drugs because they reduce mortality. ACE inhibitors or ARBs, so either of them. Beta blockers, we're going to see which. Aldosterone antagonists or the potassium sparing diuretics like spironolactone, they're very important in patients with reduced ejection fraction especially, and hydralazine plus isosorbate nitrate in a specific group of patients. So let's start with each class more specifically. ACE inhibitors, they decrease both mortality and hospitalizations in patients with heart failure. And we're especially talking about heart failure with a reduced ejection fraction. For heart failure with preserved ejection fraction, the therapeutic options really are not that much. We need to treat their hypertension, and we need to treat their coronary artery disease if they have such disease. But otherwise, the therapy in patients with HFrEF are a lot more is a lot more effective, and this is one of the mysteries that cardiological research in modern times needs to discover and is working in this direction. So what are some ACE inhibitors that we can use in heart failure? We can use enalapril. Usually the target dose is 10 milligrams twice daily. Captopril, this is the classic ACE inhibitor, which is rarely used, although in some countries, including the United States, it's still a commonly used ACE inhibitor. In Bulgaria, it's not the case. Here and in Europe, also ramipril is another ACE inhibitor that is very, very commonly used, and also perindopril and lisinopril. The target dose of lisinopril is also around 20 milligrams twice daily, although it can go up to 40 milligrams per day. It's usually taken twice again, not only once. Perindopril is also taken usually twice a day, but you can decide according to your patient's blood pressure and according to your patient's characteristic, which ACE inhibitor you can use. And if ACE inhibitors are not working, of course, you can switch to ARBs. I mean, in terms of adverse drug reactions, you know that it's really more common for ACE inhibitors to cause a dry cough. This is not the case with ARBs, which also have a mortality reduction and a decrease in hospitalizations, which is very similar to the ACE inhibitors. So we can use either ACE inhibitors or ARBs. Beta blockers also were shown to decrease mortality in patients with heart failure, but those who are already taking an ACE inhibitor and or a diuretic. And which beta blockers are used in heart failure? We have three beta blockers: carvedilol, metoprolol, succinate. You know that there is one other type of metoprolol, but here for heart failure we use metoprolol succinate and bisoprolol. So carvedilol, as you remember, this is a non-selective beta blocker, but it's a special type of non-selective beta blocker, similar to labetalol. It blocks beta 1, beta 2, and also alpha 1 receptors. As you can remember, propranolol blocks only beta 1 and beta 2, but is also non-selective, which is not the case with metoprolol and bisoprolol. They are both selective beta blockers, and they mostly act on beta 1 receptors, which are predominantly found in the heart. So this difference in the receptors that carvedilol and the other two beta blockers act on leads to actually a more commonly seen hypotension with carvedilol, because it also acts on alpha 1, and alpha 1 receptors, as you remember, they're found on the peripheral vasculature. So when they're blocked, we have vasodilation, which leads to hypotension. So it's a little bit more commonly observed in patients taking carvedilol, but carvedilol has also a greater reduction in mortality when compared to metoprolol and bisoprolol. What are some relative contraindications to beta blockers? If our patient is hypotensive or requires pressor therapy, let's say dobutamine, dopamine, or some other pressor to keep the patient's blood pressure high enough, then it's not a good idea to treat this patient with beta blockers, at least before the patient is stabilized. If our patient is bradycardic or has a high degree atrioventricular block, it's also not a good idea. Peripheral arterial disease with ischemia, it's also not a good idea, because these patients with ischemia sometimes need a little bit higher blood pressure to keep usually the lower legs from getting ischemic. So if they're not hypotensive, it's better for them. Some other management options for heart failure patients are the aldosterone receptor antagonists, or the so-called potassium sparing diuretics. And here our best and classic example is, of course, spironolactone. And it is especially useful in patients with a left ventricular ejection fraction of 35% or less. if you give spironolactone to patients with heart failure with preserved ejection fraction, it is not as effective as in patients with a reduced ejection fraction. And this is one of the must treat drugs, must include drugs in patients with heart failure with an ejection fraction of 35 or less because it reduces both morbidity and mortality. So if you want your patients to live longer, you must include this drug. Of course, if the patient doesn't have any contraindications. What can be the contraindications against the use of spironolactone? So if your patient's kidney function is reduced, so chronic kidney disease, fourth or fifth stage, which means creatinine clearance below 30 milliliters per minute, high creatinine values, so above 200 or even above 150 is a little bit risky to give spironolactone, and also in patients with hyperkalemia, so high potassium levels, because you know that such patients with when treated with spironolactone, they can also lead to severe hyperkalemia. They can get severe hyperkalemia, which can be a life-threatening condition. What is another option for patients with heart failure? Actually, it's a combination of hydralazine and isosorbate dinitrate. Both of them are vasodilatory drugs. And in the US, in African Americans especially, it was shown that for those who were NICA class 3 and class 4 and who were also taking an ACE inhibitor and a beta blocker, this combination of hydralazine and isosorbate dinitrate was shown to reduce morbidity and mortality. What are some other options to treat heart failure? Well, digoxin was a classic drug used in the past for patients with heart failure, and it is nowadays still used, although not as commonly as in the past. It causes symptom relief. Also, it can be combined in heart failure patients who also have atrial fibrillation, and it decreases hospitalizations and symptoms, but it doesn't decrease mortality. So that's why it's not a first-line drug in the treatment of heart failure. It's second or even third line. Diuretics also, they improve symptoms and they increase exercise tolerance, but again, they do not decrease mortality, but especially the loop diuretics are a very important part of patients with heart failure, especially with reduced ejection fraction, like furosemide. Anticoagulation, unless the patient has atrial fibrillation, there is no indication for their use in heart failure patients. Fish oil statins and calcium channel blockers, they are not beneficial in treating heart failure patients, and diltiazem and verapamil actually should be avoided because they can cause possible harm in patients with heart failure. Amlodipine and felodipine can be used in patients with heart failure with preserved ejection fraction. Some other drugs which are used in heart failure, Entresto is the trade name of a drug which includes two active substances, one of them sacubitril and the other one is ARB, which is valsartan. And this class is called ARNI, and it comes from angiotensin receptor blocker, which is the valsartan, and neprilysin inhibitor, which is sacubitril. So this is the first drug of this class to be approved. It was approved in 2015, and because it includes an ARB, its concomitant use with an ACE inhibitor is contraindicated, as you can guess. It has 3 doses taken twice daily, so 24 to 26 milligrams, 49 to 51 milligrams, 97 to 103 milligrams. Interesting dose combinations. And it is indicated in patients with reduced ejection fraction mostly. Unfortunately, it wasn't shown to be as effective in patients with a preserved ejection fraction, but it is highly effective in those with a reduced ejection fraction. SGLT inhibitors are another class of drugs that is nowadays very, very um, modern, let's say. And in a couple of years, probably most of patients with heart failure are going to be on SGLT2 inhibitors, even though you probably know them as anti-diabetic drugs. The last 2 years, there were several very large studies that were published, and they show really unique results in patients with diabetes and heart failure, and also in patients with heart failure without any diabetes. They were shown to reduce both mortality and morbidity, and that's why in the coming years we're probably going to see a lot of patients taking empagliflozin, canagliflozin, or especially dapagliflozin, who have heart failure and who don't have or who have also diabetes. So the study that was published, one of them actually is called DAPA-HF. DAPA is from dapagliflozin, and HF for heart failure. You can read about it online if you're interested. It's really a unique study with very, very good results. And is if you remember from third year and also from your internal medicine classes, the SGLT inhibitors should be avoided in patients with urinary tract infections because they lead to an increased glucose in the urine, and this is actually one of their effects. They block the reabsorption of glucose in the proximal tubules of the nephron, and this leads to an increased concentration of glucose in the urine. Usually there shouldn't be any glucose, so these drug classes, they act in this way, and also this is one of the reasons why they have some mild diuretic effects, because more glucose is left in the urine. There is also more fluid that is lost with the urine, so they have a mild diuretic function also. But the urinary tract infections in such patients, for obvious reasons, because when there is glucose in the urine, it's also a very good environment for bacteria to develop. This is one of the concerns regarding this class of drugs. Another very new drug, and this is an interesting actually drug. It's called omecamtiv mecarbil. It was FDA approved last year. It's still not very commonly used, That's why I included as the last drug. Um, this is actually a cardiac myosin activator, and the myosins, they're involved in the contraction of the muscle cells, and um, this leads to an increased contractility of the heart muscle, which means that omecamtiv mecarbil is similar to digoxin in that it has a positive inotropic effect. And theoretically, it's like going back to this model of thinking that when you increase contractility, so when drug has a positive inotropic effect, the patients will improve. It is probably so, but we're going to see whether it also decreases mortality, because for digoxin, you know that it decreases hospitalizations, it decreases symptoms, but it doesn't have any effect on mortality. So we're still in the wait to see whether omecamtiv mecarbil is going to have an effect on mortality. But it's one of the potential drugs to be involved in the therapy of patients with reduced ejection fraction. Here I have included some questions with cases that you can have a look when preparing for the colloquium. I'm going to send you the presentations, so we're not going to spend time on the cases and their discussion. And with this, I'd like to start talking about deep venous thrombosis and thromboembolism. So Rudolf Virchow was actually the person who coined the term embolia or emboli in 1846. And he actually named this disease and made the connection between a deep venous thrombosis going into the pulmonary arteries and occluding them. So that's why it's called pulmonary embolism, because usually the thrombus from the deep veins of usually the lower legs dislodges and goes to first of all the inferior vena cava, right atrium, right ventricle, and then to the pulmonary artery, and causes this very serious condition. There is also another term which is more commonly used. This is venous thromboembolism, and it combines both DVT and PE, because mostly the treatment of DVT and PE or pulmonary embolism are one and the same. Some risk factors for pulmonary embolism and for DVT are actually older age, male, gender, confinement to hospital if patients are especially immobile, so they cannot move, congestive heart failure, neurological disease, or an active malignancy. They all increase the risk of developing venous thromboembolism. How do we make the diagnosis of DVT? Well, here it's more than obvious that there is a problem with the left leg of this patient. Usually it's not so easy. Sometimes both legs look the same. Important thing to keep in mind is that there might be swelling, but usually there is no redness. There is redness when the patient has thrombophlebitis. So when the patient has a problem with superficial veins, but the deep veins usually do not cause redness. The patients feel that their leg is usually heavier than the other one, and um, mm, sometimes if it's not that obvious that there is a change in the perimeter of one leg with the other, you can also use an instrument like a meter to measure the perimeter of one leg and the other and to compare them. Another very specific test is to use the D-dimer, which if it's below 0.5 or below 500, according to the different laboratories. So when it's negative, you can be more than 90% sure that there is no deep venous thrombosis or pulmonary embolism. But if it's higher than that range, then uh, the patient may or may not have DVT or pulmonary embolism. Another very important test is the ultrasound. So using Doppler ultrasound to look at the deep veins of the lower legs uh, is again very sensitive and specific method to diagnose this patient. And if the DVT uh, is is negative, if the D dimer is negative, and if the ultrasound doesn't show um, any signs of DVT, then really the diagnosis becomes very improbable. Wells criteria for DVT. Um, Actually, there is also a Wells criteria for pulmonary embolism, so you can use both of them to assess the risk of your patient, whether has DVT or not. So when there is active cancer, uh, you can add 1 point. When the patient was recently bedridden or had a major surgery, 1 more point. And you can see the other ones. Entire leg swollen, 1 point. Previously documented DVT +1. And here, very importantly, alternative diagnosis to DVT as likely or more likely. Let's say your patient also has heart failure and that's why has lower leg edema, then you take out 2 points. And here you see when your patient has 3 or more points, it's a very high risk of having DVT. 1 to 2 points, moderate risk, less than 1 point, low risk. And then you can also use the Wells criteria for pulmonary embolism if you are suspecting your patient to also have pulmonary embolism. So any signs of DVT +3 points, pulmonary embolism as the #1 or most likely diagnosis +3 points. Heart rate over 100. These patients are usually tachycardic because they have a low saturation because not enough blood can go to their lungs to be oxygenated. Plus 1.5 points, and so on. And here again, over 6 points, it's high risk, 2 to 6 points, moderate risk, less than 2 points, low risk of having pulmonary embolism. What's the management of these two diseases, which we said are combined into venous thromboembolism or VTE? Well, first of all, we want to prevent the propagation of the thrombus. So we would like to make sure that the thrombus doesn't become even larger. And also, in the long term, we would like to use anticoagulation to allow for the thrombus to rise, and also for the deep veins or for the pulmonary arteries if the patient has also pulmonary embolism, to have recanalization. Um, so that being said, we use mostly anticoagulants, not antiaggregants. Uh, Antiaggregants are for usually for arterial disease, and here we have venous disease. That's why anticoagulants are used, and we can either use unfractionated heparin or UFH, or just the usual heparin, or low molecular weight heparins like LMWH immediately and for at least 5 days. After these 5 days, the patient can continue taking an oral anticoagulant. If we decide to treat the patient with an oral anticoagulant, it can be a vitamin K antagonist, which in this case should be started as early as possible, because as you know, there needs to be an overlap for at least 2 to 3 days before the vitamin K antagonists start acting in combination with heparin or low molecular weight heparin. Which treatment should we prefer, unfractionated heparin or low molecular weight heparin? Actually, several very large studies have shown that low molecular weight heparins are a better option. And here we can list naldoparin, enoxaparin, dalteparin as examples of low molecular weight heparins. Because they're much easier to dose and you don't need to monitor the APTT with the low molecular weight heparins, unlike with heparin, in which case it's sometimes very hard to achieve therapeutic levels of the APTT. Here is another very nice table comparing UFH to LMWH to fondaparinux. Fondaparinux is actually low molecular weight heparin. So the usual heparin or the unfractionated heparin has the highest molecular weight, then come the low molecular weight heparins, and then with the smallest molecular weight is actually fondaparinux. And it's also an option to use in venous thromboembolic disease. In patients with reduced creatinine clearance of below 30 milliliters per minute, both LMWH and fondaparinux should be avoided, but heparin can be used safely in this patient group when you monitor the APTT. There is also less risk of heat syndrome, so this is heparin-induced thrombocytopenia in the low molecular weight heparins, also in fondaparinux, of course. And another very big advantage of LMWH is that they're dosed subcutaneously. So when the patient has DVT or pulmonary embolism, they get 2 doses per day. But in the case with unfractionated heparin, they need to be on constant IV administration. So we use perfusers in this case. So they cannot get up from bed so freely, and they cannot move so much as in patients taking low molecular weight heparins. Also, there is an advantage in the low molecular weight heparins. You see the mortality, the major bleeding risk, and the recurrent risk of VTE are again lower in the lower molecular weight heparins. That's why they are preferred, and unfractionated heparin is gradually being replaced by the fractionated heparins. They're also called fractionated heparins because they are fractioned into lower molecular weights. Okay, another Therapy, especially in pulmonary embolism, is actually the thrombolytic therapy, but thrombolytic therapy is used in only massive forms of pulmonary embolism. So massive pulmonary embolism means that your patient is hemodynamically unstable, so low blood pressure, low oxygen saturation. If your patient had a syncope because of the pulmonary embolism, because of the low saturation, this is also an indication to use thrombolytic therapy in pulmonary embolism. The most commonly used thrombolytic therapy actually is TPA, or tissue plasminogen activator, which is alteplase, but there are also other options like tenecteplase, streptokinase is also an older thrombolytic drug, but again, they're reserved for hemodynamically unstable patients, and they have a very good effect. But the risk of bleeding with them is also very high. So that's why they're reserved for patients with only a massive form of pulmonary embolism. All other patients need to be treated with anticoagulants only. When you need to discharge your patient from the hospital, you cannot discharge your patient from the hospital on an unfractionated heparin or a fractionated heparin because it's not very practical. That's why your patient needs to continue his or her anticoagulation by taking oral drugs, and it can be vitamin K antagonists like warfarin or sanocumorol. And after that, they need to monitor their INR, and the INR should be above 2. So it should be usually between 2 or 3, according to the thrombotic risk. If the patient had a submassive pulmonary embolism and massive deep venous thrombosis, then you can aim for a little bit higher INR, so close to 3 or even 3.5, but usually it should be around 2.5, so between 2 and 3. The duration of thromboprophylaxis is actually another issue that needs discussion, and sometimes these patients will get another episode of deep venous thrombosis if their anticoagulation is stopped too early. But for most patients, they need to get at least a 6-month therapy with anticoagulations, which needs to be effective. So if they're taking a vitamin K antagonist, their INR should be constantly monitored, and their VKA dose should be according to this INR. But if this DVT or this venous thromboembolism is another episode, so if it has occurred for the second or even third time, this means that it's a better idea to leave this patient on anticoagulation for life. So never stop the anticoagulation. This is a graphic showing you the probability of recurrent venous thromboembolism in patients with a second episode. So that's why for at least 6 months they should be anticoagulated. And again, if it's a recurrent episode, for even longer, for life. This is actually, again, very helpful figure to show you that you have other options, not only vitamin K antagonists. Here you can see that for the first 5 days, they need to be given low molecular weight heparins, and also we need to start giving these patients vitamin K antagonists from day 1 until we reach an INR that is therapeutic. for the bigatran, which is direct oral anticoagulant or a DOAC. Again, for the first couple of days, we need low molecular weight heparins or unfractionated heparin, and then we can start dabigatran 150 milligrams twice daily, but without overlapping. So here we have overlap, here we don't have overlap. For rivaroxaban and apixaban, which is factor 10A inhibitors, we can actually start them directly without the need of heparins. So for rivaroxaban, we start giving 15 milligrams twice daily. So it should be taken with food. It's very important because when it is not taken with food, its bioavailability can actually decrease by up to 30-35%. And after 21 days or 3 weeks of therapy with twice daily 50 milligrams rivaroxaban, we switch to 20 milligrams once daily for 6 months, and after that 10 milligrams daily if we would like to continue the anticoagulation. For apixaban, the first part of the therapy is actually 7 days. So apixaban has 2.5 milligram tablets and 5 milligram tablets. But in this case, we need 10 milligrams twice daily. So we give 2 tablets in the morning and 2 tablets at night for 7 days, after which we start giving the patient 5 milligrams in the morning and 5 milligrams at night. So 5 milligrams twice daily for 6 months, and after which we can go to 2.5 milligrams twice daily. For edoxaban, which is again a factor 10A inhibitor, there is still no indication to start treating venous thromboembolism right away. That's why for the first 5 days, we need to cover the patient with either low molecular weight heparin or unfractionated heparin. And after that, we can continue with edoxaban 60 milligrams daily. The important thing here is vitamin K antagonists, we always bridge or we always overlap for the first couple of days. For the other anticoagulants, we do not overlap. Okay, this is it for today. Thank you for your attention. If you have any questions, you can ask them now. For the next exercise, I see that I am now in the clinical pharmacology group. So for the next exercise, you can look for the clinical pharmacology, not the internal medicine from last year, as was the case for today. So if it is all right with you, we can do the next exercise on next Monday. Let me just check if it will be all right. Yes. So again, let's say 4 o'clock next Monday, same time. Okay. Okay. So great. What are we going to talk about next time? We're going to talk about asthma and COPD. This is our next exercise. For right now, you can review all the things we have studied so far, especially the antihypertensive drugs, drugs that are used in heart failure therapy, which are mostly the same. So ACE inhibitors and beta blockers, you should know them really well. Also anticoagulants and antiplatelets. And from next time on, you can start reviewing also the COPD and asthma drugs. And probably our colloquium is going to be not on the first 6 exercises as was the plan, but it will probably be on the first 8 exercises. So for the next 2 weeks, you're not going to have a colloquium. Next time we can talk about it in more detail, and it will be an online colloquium. So if you have any questions, we can discuss them all 1 week before the preparation. Okay. In this case, I wish you good evening and stay safe. If you have questions, you can call me or email me. Otherwise, see you next week on Monday, same time. Bye bye.
You are currently the only person in this conference.